delivered by Caribbean and African doctors. Have you been on the Caribbean and African Targeted Health Improvement Program, CAHN Health Hour? If not, join us as you're missing out on health information that could help you, your friends, or your loved ones. These sessions are all about educating our communities to look after themselves better. Our Black GPs and consultants present on topics such as women's health, men's health, cancers, heart-related problems, respiratory disease, sickle cell, maternal health, lupus, and much, much more. Tell others, invite them along. Join us on Zoom, YouTube, or Facebook. For more info, visit cahn.org.uk/health hour. Also, email health@cahn.org.uk or call or text 077 10 022 382. CAHN is funded by the National Lottery Community Fund.
Hello and good morning once again. I welcome everyone to this morning's Health Hour session, and it's an absolute pleasure to be your host for today. We value your time and joining in this morning with us. My name is Dr. Dinah Asante and I'm a GP. And today we have another interesting session and a very experienced resource person who has been on the CAHN Health Hour in the past. So essentially today we will be talking about complications of diabetes, specifically focusing on eye and foot complications, amongst others. We do have a consultant who is Dr. Tolu Shonibare. She has been with us before and given us some really useful sessions. So we will have the pleasure of our consultant in diabetes and endocrine to take us through this session. There will be an opportunity for a Q&A session at the end where we go through the questions that have been posted in the chat box or on the various forums. So please do post your questions as we go along, post them in the chat box, send them through so that we would have them ready when it gets to the Q&A session. And we will endeavor to answer everyone's question as much as possible. If you have any specific emails, you can also send them to health@cahn.org.uk. So without wasting much time, I would like to welcome you all once again, and most importantly, to welcome our guest speaker for today, our consultant in diabetes and endocrinology, Dr. Tolulope Shonibare. Over to you, Dr. Tolu. Thank you.
Morning, thank you very much for having me back. So hopefully today we're going to try and cover diabetes complications in terms of foot and eye care. So before I get started, have you got the slides, please? Right, so today we're going to focus on managing diabetes, especially looking at eye and foot care and all the complications that can arise with that. Next slide, please. So before we get into that, I just felt that it would be best to do a quick recap of what we've previously talked about in terms of managing, in terms of what diabetes is. So as you're aware, diabetes is a disorder of glucose regulation, and that essentially is a problem of the pancreas. We've previously talked about how we define diabetes in terms of the blood glucose measurements, and how also we diagnose diabetes. We've also previously talked about the types of diabetes. So there's two types: type 1 diabetes, where it's an autoimmune condition where the body essentially fights itself and destroys the pancreas. And then there's type 2 diabetes, which develops later on in life. And that's usually due to some degree genetics, but mainly due to lifestyle. Next slide, please. We've also talked about the symptoms that people can present with diabetes, such as thirst, urinating quite frequently, weight loss, feeling tired, blurred vision, thrush, and prolonged wound healing. If we just go to the next slide, please. And also we've talked about the previous complications of we've previously talked about the complications of diabetes. So kidney problems, heart attacks, problems with the eyes, problems with the foot, sexual health problems, and we've also talked about diabetes and pregnancy. But today specifically, we're going to focus on the eyes and the foot. Next slide, please. So in terms of general management of diabetes, so if you have been diagnosed with diabetes, every year you would have an annual screen, or what I like to call the diabetes MOT. And you would expect to have a blood pressure check, you'd expect to have your weight checked and your body mass index calculated. You'll also have some blood tests, so that will be checking your HbA1c, which is the long range average of your glucose. You also have your cholesterol checked. You'll have your kidney and liver check as well. You'll also have a urine test, but in addition to that, you should have a foot assessment as well as a retinal screen, which is a diabetes eye check. Next slide, please. So going on to diabetes and eye complications. So in diabetes, more than 30 people a week lose their vision because of diabetes. So this is quite serious. And diabetes can affect the eyes in many ways. Particularly the retina. So the retina is the back of the eye, which essentially has lots of delicate structures. So the retina has lots of blood vessels that feed the back of the eye. And it's also got lots of little molecules or cells, which I like to call, they're light sensitive cells, and I like to call them little cameras. And they capture all the images, they capture all the information and send it to the brain. And in diabetes, that can affect, it can affect the back of the retina. So next slide, please. So as I mentioned before, diabetes can lead to sight loss, and it's actually one of the most common causes for blindness worldwide. So between the ages of 20 to 78, it's actually the leading cause of blindness. And at this point in time, it's estimated that 100 people or 100 million people have had their vision affected due to diabetes. If you've had diabetes for a very long time, your risk of having problems with your eyes increases. And also, if your diabetes hasn't been managed properly, or your blood pressure control, your blood pressure hasn't been well controlled, then this increases your risk of having problems with your eyes. In England, there is a national retinal screening program. And essentially, if you have been diagnosed with diabetes, you should be registered on this program. And every year you should get a letter inviting you for a retinal screen. And the picture on the right just shows the sort of machines they use. So it's quite a clever machine where they dilate the eyes and they look at the back of the retina to see how healthy or unhealthy it is. And then they would decide whether or not you need treatment. Next slide, please. So in terms of how people can present with diabetes and eye disease, the most common presentation, or the most common symptom that people experience is blurred vision. So this could be blurred vision because the back of the eye is being affected, or sometimes if your glucose is changing within your blood, because you do have a bit of glucose in the eyes as well. So if the glucose is changing quite frequently, this could lead to blurred vision. And then there's something which we call diabetic retinopathy, and this is when the back of the this is when the retina is affected. And essentially, what happens is that you can have destruction of the blood vessels that feed the retina. You can get cholesterol buildup. You can also get reduced or lack of oxygen, and all of this leads to different stages of diabetic retinopathy. So there's the background changes which can happen. There's proliferative, which means that some of the blood vessels are starting to grow excessively, and there's also non-proliferative diabetic retinopathy, and there's also something called maculopathy. Sometimes people who have diabetes and eye disease can also present with floaters and spots, so they notice strange things floating in their eye and they can't quite place where it's coming from. And usually that's due to little bits of dead tissue floating within the eye. If you have diabetes, you're twice as likely to develop cataracts or glaucoma. Next slide, please. So this is just a picture of what a healthy retina looks like. So the bright yellow disc is called the optic nerve, and that's the main nerve that feeds the back of the eye, and that's the nerve that connects the eyes to the brain. So as I mentioned before, in the retina, you can see some really nice nice well-organized blood vessels, which essentially keep the back of the eye healthy. And they feed these cells which I call the camera cells, that capture all the images. So all that information is then sent through the optic nerve to the brain. And that helps you to interpret. So what you see in front of you is as a result of what the retina has captured, the images the retina has captured and sent through the optic nerve to the brain. So next slide, please. So these two slides are an example of how things could go wrong with diabetes and eye disease. So the slide on the picture on the left shows those little black arrows show that the blood vessels, if you remember the previous slide, the blood vessels on the left are starting to burst. So they look like little spots or little blobs in the background there. And if you compare this slide to the others and to the previous slide, you can see that the blood vessels aren't quite as healthy as they looked in the previous slide. And then the slide on the right shows, similar to the left, that there's lots of little blobs. So there's signs that the blood vessels are bursting. But then there's also these white pale spots as well, and to the right. And those are fat deposits. So these are signs that things are starting to go wrong in the back of the eye. Next slide, please. Excuse me, on the left, you can see that the optic nerve, which was the bright disc previously, was, if you remember the first slide, that was quite well shaped, but you can see that's starting to get blurred now. And if you look carefully with where all the little black arrows are, there's lots of blood vessels being formed, new blood vessels. And if you look at the way the blood vessels are in the back of the retina, they look quite disorganized, and it seems like there's a lot of chaos going on there. And then if you look to the right slide, the slide on the right, or the picture on the right, you can see there's blood. And that's what happens. That's a consequence of when you start to have new blood vessel formation in the back of the eye. And the problem is that these blood vessels that are forming aren't very good quality blood vessels. And as a result, if there's a high blood pressure, or if someone has a high blood pressure, these blood vessels burst very easily. So that's why we always stress that people who have eye disease should also ensure that their blood pressure should be well controlled. So this is one of the reasons why we're also interested in blood pressure and diabetes. Next slide, please. So this slide essentially shows someone who has had laser therapy. So if you have had lots of blood vessels growing in the back of the eye, what the ophthalmologist would try to do is prevent any new blood vessels from forming. Because I said these new blood vessels that form aren't quality blood vessels, and they can cause a lot more trouble. So the little white spots, you can see they're well organized. They're just essentially where the laser has made contact with the retina. And essentially they use laser therapy all around the retina to preserve the already formed blood vessels, but to stop any further blood vessels from forming. Next slide, please. So if you have diabetes and eye disease, there's a few things which you can do to try and help or prevent things from getting worse. And one of them is, I think the take-home message essentially is to make sure that you stay on track. So if you are being given medication for your diabetes, please ensure that you are compliant with your medication. Also make sure that you're checking your glucose to make sure that if things are getting out of hand, then you can seek help early. Make sure that you exercise, you keep your heart healthy, and if you can, try to stop smoking, because smoking definitely makes things worse. So next slide, please. So I'm going to go to the second part of the talk now, and we're going to focus on the feet. Next slide. So diabetes and foot disease. And so if I'll just give you a bit of statistics. So diabetes is one of the most common causes of amputations worldwide. And if you have diabetes, you're 15 times more likely to have an amputation. In England, that equates to 169 amputations a week. That's 24 amputations a day. And that's one amputation an hour. So that is quite serious. And if you've had previous foot problems, your risk of having diabetes and your risk of having foot problems in the future is increased. And essentially what happens in diabetes and foot disease is that because of the high glucose or the high sugar level within the body, you start to get nerve damage in the foot and also in the legs as well. And you also start to have a buildup of cholesterol within the blood vessels. And if you combine all of these together, this can lead to foot problems. Next slide. So the typical symptoms that people, or the typical things that we would see in a diabetes foot clinic are people who have reduced sensation or reduced feeling in their legs or in their feet. And we call this peripheral neuropathy. And essentially, this is mainly due to nerve damage from the diabetes. Some people have peripheral vascular disease. They have reduced blood flow to their feet. And this is as a result of compromised blood vessels, or that there's a lot of cholesterol buildup within the blood vessels. So as a result, there's not enough blood flow to the legs, and this increases the risk of infections, ulcers, skin infections. And then, with diabetes with diabetes, when people lose the nerve endings in their feet, what happens is that they don't have any awareness of, for instance, if they're walking on a hard floor, they tend to lose awareness, and so they tend to stamp on the floor because they're trying to reinforce the fact that they're walking, because they're not getting any information from their feet to say that they're walking on a hard floor. And sometimes people can develop something called Charcot's foot disease, where you get lots of fractures in the foot because of the numbness in the foot, and you get a deformity. And I'll show you a picture of that in a second. People who have complications with their foot, sometimes this can lead to quite bad infection and sepsis, and sometimes it can lead to a complete dead foot. And if this is not corrected properly, or if it's not salvageable, then ultimately it would lead to an amputation. Next slide, please. So typical symptoms, when people have a foot disease, typical symptoms that people present with are sometimes they usually start with a tingling sensation, or what people describe as pins and needles. Sometimes people can have burning pain, and then people can start to have little blisters, ulcers, hard skin, and then also people can have ingrowing toenails that are very difficult to treat, or sometimes a fungal infection between the toes or on the nail. And then people lose the feeling, so they have numbness in the legs or in the feet. Sometimes people are prone to infection, and they have swollen feet, redness in the skin. And some people also describe lack of sweating in the feet, so they don't sweat as much in the feet. And if you think about sweating is a protective way, is a protective mechanism to try and get rid of dirt in the feet. So if you lose that, then dirt is more likely to stick to the skin. And then also, if people have diabetes, if they have a cut, or even if it's just a simple cut in the foot, sometimes it takes a long time to heal, and that's because the blood supply to the foot is compromised and the nerve endings are damaged. Sometimes people could have discoloration or discolored toes, and then also they might notice that the temperature of the feet is either very warm or very hot. If people are starting to develop problems with the blood vessels in their legs, when they walk, they tend to have cramp in the back of their calves, and this is what we call angina of the feet. So this is a sign that they have peripheral vascular disease. And if a patient has a wound, sometimes the smell could be very bad. It can have a very bad odor because they have really nasty microorganisms or nasty bacteria growing on that wound. Next slide, please. So if you do have diabetes, every year, as I mentioned before, you should have an annual foot check. And when you have your annual foot check, you will be categorized or risk categorized depending on whether you're a high risk, medium risk, or low risk. And we have a traffic light system. So if you're classed as being green risk or a low risk, so essentially that your risk is green. So you would essentially, all that's needed is that you'll just have your annual diabetes foot checks. And essentially this means that you might have a little bit of numbness in the legs, but there's nothing else for you to worry about. They'll just give you some advice and make sure that you maintain good health, and then they'll ask you to come back the next year. If you're classed as a medium risks, usually this is signs that you're starting to show some signs of more serious diabetes foot disease. So typically people would present with tingling. There might be a deformity. There might be a small ulcer on the in the foot. Some people might start to show signs of peripheral vascular disease. So the signs that the blood flow is a little bit compromised. And usually you would get managed by the foot protection team. This is the foot protection team usually in the community. If you're classed as having high risk, so this means that you have a combination of reduced sensation or numbness in the feet, you've got an ulcer, you've got deformity, you've got compromised blood supply, and usually you would get managed by the hospital. So, and you would be seen a lot more than every year. So people, if you're classed as low risk, you'll be seen every year. If you're classed as medium risk, you'll be seen every 3 to 6 months. But if you're quite high risk, you will be seen every 1 to 2 months. And then there's people who have what we call active foot disease. So they've got an active ulcer or an active foot problem that requires the expertise of a foot surgeon or a vascular surgeon. And usually patients would be seen every 1 to 2 weeks. Next slide, please. So essentially, if you're classed as low risk, then you don't have to worry too much. As long as you look after yourself, you'll be seen every year. But if you're classed as amber risk or red or high risk, then you will be referred to the foot protection team. And what the foot protection team are trying to achieve is to stop you from having an amputation. And they try to do this through many ways. So if you have a wound, they'll try to help you with the wound healing. If you have an infection, you'll be given antibiotics. Or also they'll try to prevent you from having an infection. If you have an ulcer, which isn't too bad, they might give you what I call an offloading boot, and I'll show you a picture of that in a second. And essentially that's a boot that takes off the pressure from the ulcer so that it can heal properly. If you have any dead tissue around a wound, they will try to remove the dead tissue either physically or through other medical means, and I'll explain that in a second. If you have any problems with your blood vessels, then they will try to do something called revascularization. And this is where vascular surgeons come in, and they will try to open up the blood vessels through an angioplasty so that they can improve the blood flow to the legs and to the foot. And if everything fails, then the next stage would be an amputation, because if you amputate the dead part of the foot or the dead part of the tissue, then it's unlikely that if there's an infection, it would spread. Next slide, please. So I'm just going to go to showing you pictures, and the reason why I've put this slide up is just to warn you. So if you have a sensitive stomach, you can look away. The pictures aren't too graphic, but if you have a sensitive stomach, then my suggestion is that you look away. So next slide, please. So these are examples of what we see in the foot clinic. So the slide on the left is someone who's got essentially gangrene or an infection of the middle toe. So you can see that the middle toe is discolored. And underneath that, there's almost like a yellow collection. And that's a sign that there's pus. And it's possibly that the fourth toe is also affected as well. So usually they would try to drain this or remove the pus and try and help with the blood flow to the foot so as to promote wound healing. If all else fails and if the patient doesn't get better with antibiotics, then they would have to consider amputating that toe. And then the slide on the right shows someone who's got Charcot's foot, and you can see that the foot is slightly deformed. So when people have Charcot's foot, they lose the arch in the foot. So you can see that this foot is slightly deformed, and you can see an ulcer which looks quite deep in the middle of the foot. Next slide, please. And then the slide on the left shows someone who's got quite a deep ulcer, and if you look carefully, you can also see some bone there as well. So this patient has probably got a skin infection, which started off as simple ulcer and has got deeper and deeper and deeper and has eaten all the way to the bone. So typically what the foot protection team will try to do is try and reduce the infection, clear away all the dead tissue, and then improve the blood supply so that the wound can heal. They'll also apply a dressing on it as well to try and help with the healing. And then the picture on the right is quite interesting. So you can see that this patient's middle three toes have turned completely black. And essentially what that means is that the blood supply is completely compromised. In some cases, if the vascular surgeons are able to salvage that, then they might be able to improve the blood flow to the toes. But in all honesty, looking at that foot, there's signs that the toes are starting to die off. And typically, this is what we call dry gangrene. So the toes become mummified, and eventually the toes will fall off, or they'll have to remove them surgically. Next slide, please. So I talked about offloading techniques. So if you have an active ulcer, or if a patient has an active ulcer, you will be given something of footwear that looks like this. And essentially, these are quite cleverly designed footwear to help take off the pressure or the gravity from the wound, so that when you're walking, this allows for the ulcers to heal properly. Next slide, please. And if people have dead tissue on their foot, sometimes they can physically try to do debridement. So they surgically try to get rid of the dead tissue. But sometimes we use what we call medical maggots. So as you're aware, maggots are creatures that like to feed on dead tissue. But medical science has taken advantage of this, and what they've tried to do is create this. They've cultured these maggots. They're grown in the lab, so they're clean maggots. They're sterile, and they're grown in the lab, and they're put in a bio bag of what looks like a tea bag. and they put them on top of the ulcer or top of where the wound is, and they're covered up with the dressing. A few days later, so if you look at the picture on the right at the bottom, you can see that the maggots have gone from looking tiny to obviously being well fed, and essentially they fed on the dead tissue. So this is a safe way of trying to get rid of dead tissue in the foot. And I know, if you haven't got a strong stomach, it does seem quite alarming, but actually this does not increase the risk of infection because these are clean maggots. So these maggots are cultured in the lab. Next slide, please. So if all else has failed, so if someone has had debridement, they've been treated with infection, and they've had a bone infection, and everything else has failed, then the patient will have to have an amputation. And essentially, the reasoning behind having an amputation is to stop the infection from spreading. Because if you left it, if someone's got a limb that's really infected, it'll just keep spreading and spreading, can lead to sepsis, and it can lead to death in some cases. So sometimes the best thing to do is to have an amputation. So the patient on the left has had a 4-foot amputation. So essentially, they've had half of their foot amputated. And the patient on the right has had an amputation, a below-knee amputation. Sometimes if the infection is really bad, we go even much higher, so above the knee. Next slide, please. So if you have foot disease, diabetes and foot disease, the general advice we give to everyone is to make sure that you inspect your feet every day. And essentially, when you come out of the shower in the morning, that's the best time to check. Just have a quick look between your toes, look under your feet. Have you got any hard skin? Have you got any tears, any ulcers? If you do notice something, do something about it. Also look at your footwear on a daily basis. So inspect them, because sometimes people can have little stones in their socks, in their shoes, and those stones could bore a hole into their foot, and that could that could bore a hole into the foot, and that could lead to an ulcer. If you have sensitive feet or you have reduced sensation, please make sure you wear appropriate footwear. So footwear that's got enough padding, and enough padding that takes away the pressure, and it's also the right fit as well. If you have problems with so if you're able to cut your toenails, you should do this carefully, bearing in mind that if you have problems with your eyes, so if you've developed diabetes, eye problems, please don't cut your toenails. Get someone else to do it for you. Because if you try to do it, you could cut your skin, and that could lead to even more problems. So if you're unable to cut your toenails, get someone else to do it for you. Make sure you stay active, because if you stay active, that improves your general health and improves the blood flow to the legs. Don't walk barefoot. So make sure you don't walk barefoot, because especially when people go on holiday. So quite commonly, we see people going to holiday in Spain, and then they come back with a nail at the bottom of their foot, and they haven't noticed because they don't have any sensation. So we always advise, try not to walk barefoot. Avoid hot water bottles. So sometimes people who have pain in their feet try to use hot water bottles to try and make it feel better. But sometimes, because they lose the sensation in their feet, what happens is the hot water bottle starts to burn the skin, and that can create problems as well. And that's the same with wheat bags. Always, if you're getting into the shower or into the bath, always make sure that you check your temperature and make sure it's not too hot. If you are a smoker, try to stop smoking or cut down your smoking. If you try and make sure that you improve your glucose levels and your blood pressure as well as your cholesterol. So make sure you attend your diabetes checks every time. And then if you are referred to the podiatry clinic or the foot protection team, please make sure you attend your appointments. Next slide, please. So if you do have an annual foot check, so if you're classed as a low risk patient, you should have an annual foot check. And it's the things you expect every year you have your foot check. Your shoes should be inspected, and you should have a general foot inspection. This would include checking your pulses. You'd also have what we call a pinprick and a cotton ball check, and that's just checking for the sensation. And you should also have your pulses checked, and the vibration with a tuning fork. I don't know if you can see the diagrams, but you expect to see these tools being provided when you're having your annual foot check. And next slide, please. So I noticed that there was a question in the comments that flashed up about footwear. So this is a picture of someone's shoes. This is a patient of ours that came to the foot clinic one day, and you can see that his shoes are completely worn through, and he didn't realize because he's lost the sensation in his feet. So you can see that the soles are worn through. So what we always say is always inspect your shoes and make sure that if they're wearing out, get new ones. If you also notice that your shoes, you can't seem to find the right fit for your shoes, there's specialist shops which you can go to, and they can advise special shoes for you. Next slide, please. So this is the end of the talk now. So if you have diabetes or foot disease, the first thing you need to know is know your risk. So if you have been to your annual foot check and they've said you're high risk, you're amber risk, know your risk. Make sure you stay on track with your blood glucose, with your cholesterol, and with your blood pressure. Make sure you attend your appointments, because that's very important, because if there's a problem, something can be done about it. If you notice a problem with your eyes, with your vision, or a problem with your foot, please take action promptly. Don't sit on it, do something about it. And if you do notice a problem, you should have contact numbers. So you should have contact numbers of your foot, the foot clinic, or you should have contact numbers for the ophthalmologist or your GP, so that if there's a problem, you know who to contact immediately. Next slide, please. So this is a slide for just useful resources. So if you go on Diabetes UK, there's lots of useful information for if you have diabetes and what to do about it, and lots of practical health tips. And then there's also diabetes.co.uk, there's nice.org. So there's lots of useful resources available, and I'd encourage you to use them. Thank you.
Thank you so much. Thank you once again. This has been as good as ever. Last week you gave us a useful insight about diabetes, and today you've taken us even to another level. Dr. Shonibari, we're really grateful. So just to summarize, you've told us that diabetes can affect multiple organs and cause problems in every single organ. You focused on the foot and the eye today. It's actually interesting that some of the statistics that you raised about the eye, the fact that more than 30 people a week would lose their vision. That is staggering. That's a lot of people if we don't control our diabetes properly. The fact that it is one of the leading causes of blindness as well, and more than 100 million people worldwide. So very important that we sort of look after ourselves and make sure our diabetes is well controlled. And also things like making sure that we're checking our footwear, checking, our feet, making sure we're attending those appointments that we get the letters come through for. So our screening, which sometimes some people tend to ignore, please let's attend those screening programs. My chat box is right in my face. That's trying to distract me a bit. Yes, so make sure we're attending those screening programs. So obviously, after such an insightful discussion, we do have a number of questions for you. I guess we've all learned a lot, and I have written down a few things that I've learned as well. So thank you so much, Dr. Tolley, for that. Right. So I'd like to ask one of the questions which popped up. It's about data, about whether we do have any quality data on diabetes, eye disease, specifically in the Black communities in the UK, and if you can shed some light on that, please.
Unfortunately, there's no data, but I think that it can easily be made available. With the Diabetes Retinal Screen Programme, all the data is pulled. So if we specifically made inquiry into the data, I'm sure that that's something which we can update and we can obtain, but I don't have the data to hand, but I'm sure it's something that we can, because it's all audited every year. So I'm sure that's data which we can look at to see if there's a disproportionate amount of Black people being affected. But I don't have the data to hand.
Right, thank you. Thank you. Okay, so that's probably something which could be looked into, isn't it? Because there are a massive, as you've said, a disproportionate number of Black people affected.
Yes, no, with
diabetes generally.
Yeah.
Generally, isn't it? Yeah. Yes, yeah, okay. And is it possible for someone to specifically tell, so if someone is getting, say, numbness or pins and needles or any change of sensation in their feet, is there any way for them to know whether this is coming from a nerve problem, so like the diabetes eating up the nerves, or whether this is a vascular problem, something to do with their vessels?
So typically, if you go for your foot check, they will check for both, actually. If you the foot check essentially looks at all aspects. So it looks at the sensation, but I also look at the blood flow. So when your pulses are examined, if they can't feel the pulses properly, then they will use a specific machine, an ultrasound Doppler machine. and that will give you a bit more information. So if people are experiencing numbness in their feet, then they can tell whether this is just primarily just nerve damage or if there's an additional vascular problem as well. So usually the foot check, it should expose what the problem is, what the underlying problem is.
Okay. But essentially, if we feel anything, we should probably go and see someone anyway, isn't it?
Absolutely,
Right.
yes. Yeah.
Thank you. And you mentioned about the specific shoes, and you showed us some really lovely photos, which is useful to put it in context for us. So someone would like to know, are there any particular ones that people should, so we tend to say sensible footwear. Is there anything particular that can be recommended, or is it as basic as sensible footwear then?
So if you've got Charcot's foot disease, so if you've already got established foot problems with diabetes, so these are patients in the moderate or the high risk, you would have shoes prescribed by the podiatry department, and you can. So so if you're going to the foot protection team, we do order specific shoes, and these are made to fit. If you're someone who's classed as low risk, then we would ask you to wear shoes that are well fitted, so they're not too tight, and then also shoes that you feel comfortable in. And then also they've got a good sole, they've got good padding underneath, because sometimes people can wear shoes with very thin soles, and then if you step on a nail, it goes through. So you want a good quality shoe where it's got enough padding. Sometimes that requires insoles, but then it's also got a good fit as well, so there's not friction around the edges.
Okay. Thank you.
But if you have established foot disease, then you should be seen by the podiatry team, and they would. So we have sometimes there's even more pictures of examples of footwear which we have, and they are made depending on the shape of the person's foot. So these are made to fit, so they're custom made.
Right. Okay. So it's important that we get the right footwear so that we prevent any injury or damage to our feet. To worsen a pre-existing problem. And the pins and needles or the sensation loss that people can get in the feet with diabetic foot disease. So someone would like to know, doctor, is it just in the feet, or can we have them in the legs or other parts of the lower limb, please? And
so you can get, so usually it starts with the feet, and there's something which in diabetes which we call glove and stocking neuropathy. So essentially it starts with the feet, and then it starts building. So as it gets worse and worse, it starts to go up almost like a stocking to the ankle and then to the leg. And then if you've had diabetes for long enough, it starts to affect the hands as well. Usually it's rare, but typically people who've had diabetes for a very long time, we call that glove and stocking neuropathy. And essentially, imagine if you're wearing gloves and socks, you would lose the sensation in that pattern. So yes, it can affect other places. And it starts with the toes, and then it builds up and gradually gets worse.
And is this something that can be reversed? Can it get better? So if you progress to a really bad neuropathy stage where you've not just got in your feet, as up your legs and probably even in your hands, is there any way of reversing this, or is this an irreversible process?
To some degree, it's irreversible, but I think what we aim to do is to stop it from getting any worse. And the way to stop it from getting worse is general control of the diabetes, the blood pressure, control of all the risk factors. There are medications which people can use, such as duloxetine, which help with the pain and some of the symptoms. So that alleviates the symptoms. But specifically, once it's established, it's very difficult to reverse it, but it can be reversed if it's caught early and it's dealt with early. It can, to some degree, be improved, but not completely reversed. I think you froze there.
I'm sorry, viewers. I'm really sorry. I think my internet dropped over there and you probably lost me for a bit. So yeah. I just noticed a freeze, and I think we got to where we were talking about the fact that it could be reversed, but then obviously if the diabetes isn't well controlled, this is irreversible. I lost the rest of it, but I guess you've answered that question, haven't you?
Yes, I have.
Okay.
Yeah.
Yeah, my apologies once again. Technology is great when it works, isn't it? Okay. So someone says she can see veins and arteries and vessels all over her leg and on the side of her ankle, and her skin appears quite thin as well. Is this something that she should be worrying about, or is this something that can be comfortably ignored?
So is this, I'm guessing the patient, this person has diabetes.
Yes, please.
So with age, with age, the structure, or it's essentially the integrity of the blood vessels, tends to degrade to some degree anyway. But if you're noticing a more prominence with your blood vessels, it could be it's a varicose vein. But sometimes it could be the fact there's a blood clot. So if there's pain, there's swelling, or there's particular swelling, then I would get it checked. But if it's just that the blood vessels are more prominent than previously, it's just sometimes it just happens with age, and that's just because the integrity of the blood vessels aren't as strong, and also the skin, the collagen of the skin, which normally hides the blood vessels, the collagen is breaking down. So that's why they appear more apparent than previously.
Thank you. So there could be a number of things. So do get them checked. If you're not sure, speak to your doctor or speak to your GP, and they can hopefully work out what the problem might be for you. I have cramps in my calf when I walk, someone says. What can I do about that, please?
I would advise to get that checked. So that's what we call angina of the feet. So if you're having cramps when you walk, that could suggest that the blood vessels to your legs are compromised. So I would book a session with your GP and possible referral to a vascular surgeon so that they can look, they do something called an angiography, and they look at the blood vessels to see if there's any blood vessels that are starting to show signs of narrowing. So if you have cramps each time you walk, that needs to be checked. So please go get checked.
So please get checked. And as Dr. Tolu said at the beginning, our lifestyle is very important. So things like smoking habits, weight, our diet, etc. Anything we can do to improve our risk factors would be useful as well. What is the success rate for verruca treatment, and what advice would you give? So if people have verrucae or warts on presumably on the feet, I guess in this instance, because we're talking about feet, what advice would you give regarding this?
So if the patient has diabetes, I don't know about the success rates, but they can be successfully treated. If you have, because I think there are over-the-counter medicines for verrucas. So if you don't have diabetes, you can use over-the-counter medication. But if you have diabetes, then I'd suggest you see a podiatrist, because they would have the tools in terms of being able to treat them and then also monitor them. Because sometimes in treating them, you can create another problem. So I would suggest that if you have diabetes, let a professional sort that out. Let a podiatrist sort that out for you.
Thank you. And yes, she's right. For those who don't have diabetes, there are stuff over the counter as well that you can get. But again, as Dr. Tolle said, speak to a professional so that you get the right checks done and you don't cause harm rather than good. Dr. Tolle, we'll take a few questions about the eye, and then we'll probably come back to the feet in a minute. So again, in relation to diabetic eye disease, can the blindness be reversed? Can the blindness be reversed, or even the stages of the retinopathy that people go through? Can that be reversed at all?
No, so I think once a patient has experienced sight loss, it's very unlikely that the sight loss can be reversed. But usually the stages with retinopathy is usually the background stages. So that's the first stage. So each time you have a check, what we're aiming to do is to stop you from progressing to the non-progressive and then the progressive and then the maculopathy. So usually when people get to the proliferative stage, which is stage 3, then they start to talk about, the ophthalmologist will start to talk about laser therapy. So there are medications which they can do to stop progression. But once you've got to that stage, it's very difficult for it to be reversed. But again, the best way to try and stop things from getting worse is managing the diabetes. And then if you notice in the talk, I talked about blood pressure, because in the back of the eyes with diabetes, they have these little blood vessels, which aren't they're not quality blood vessels that start to form in the back of the eyes with diabetes. And if you have a high blood pressure, that puts pressure on the blood vessels and they burst and they can bleed. And that could be quite catastrophic. So it's not just managing the diabetes, it's also managing your blood pressure as well and your cholesterol.
Hello, I'm really not having a good day today, am I?
Let me first for a second again.
Oh dear. Right. Okay. I hope this doesn't happen again, because I have had to reboot to make sure that I'm a bit stable. But anyway, we'll carry on. We'll carry on as we were. Apologies once again, our lovely viewers, for the break in transmission. Okay. So on the topic of laser treatment, if someone has had laser treatment before, are they able to have further laser treatment, or is there a cap to the number of laser treatments that you can have to complicated eyes and diabetes at all?
Yeah, so if you've had laser treatment before, then yes, you can have further laser treatment. But usually the cap is decided, I think it's 3 times, but I think the cap is decided by the ophthalmologist. Because there's a point where they've lasered all of the retina and there's nowhere else to laser. But usually that's decided by the ophthalmologist as to when they're going to stop lasering.
Yes, okay, all right. And there are lots of comments in there, obviously thanking you for a wonderful session, insightful, educative session. There are also comments about people saying it is very important to attend these screening programs. So do make sure you go for them. And also testimonies of people saying that diabetes does cause a lot of trouble. So make sure you're engaging with your monitoring process. And we agree with that completely. Someone has also said about the fact that she has diabetes in her family. She has ocular hypertension, but then finds the whole sort of process of being examined or being checked a bit daunting and sometimes a bit disappointing, because she feels as though she's not getting the kind of service that she would want. So they're finding this talk quite useful, learning all the things that you've said. Also, we've got another question about, are there any preventative podiatry services? Are there any preventative podiatry services? And also, if I am a diabetic and the nerve in my feet are painful and I have a lot of swelling, is there anything you can recommend? So I think that's sort of tied in with what you've said already, but I'll put those two together for you. So preventative podiatry services, and you know, she notices her feet swell up when she eats sweet stuff. Is there anything you can recommend, basically?
So the there are preventative podiatry services. So there's the community foot protection team, and these come in different grades. So you've got some podiatrists work as private, and sometimes they're contracted. They have contracts with GP practices where patients can be referred. So for instance, someone who's got diabetic retinopathy, they can't cut their toenails, and I would advise against trying to cut the toenails. The GP can essentially liaise with a podiatrist within the community, so to help so they have access to a podiatrist. And these are the preventative podiatrists to stop, because if someone with eye problems cuts the toenails and there's an ulcer, then that's going to lead to an array of complications in the future. So yes, there are preventative podiatrists, these usually in community. There's also private podiatrists as well, and I believe that some of the high streets, I think Boots are starting to look into podiatry services, so community podiatrists, but these are mainly for low risk. If you are moderate risk or high risk, then I would suggest that you're either under an established foot protection team or the hospital. So if you're high risk, then you need to be under the foot team in the hospital.
Okay. And also there are domiciliary services as well. So I know of some of our elderly patients who can't go to some of these appointments, and there are some domiciliary services, isn't it, who can come to your home to offer these services. I don't think those are necessarily on the NHS, but they might be available privately. So if people are housebound or people are unable to go to these regular checks, then they can have that done privately. And then there's another question about how often do you have the foot check done, which Doc has said that's usually an annual foot check. But each time you have your diabetic checks, even in the surgery, you would have these things looked at. But the formal sort of annual screening tends to be the big one once a year. And same for the retinopathy, unless they call you sooner, unless the screening team invites you sooner. Are there any particular things that Black people need to be aware of for prevention, Dr. Shonibari, in terms of, for instance, natural products, plant-based products? Is there anything specific that you might recommend? please.
Is this for diabetes in general or for foot
This is
problems?
a generic question, so I'm assuming this would be for diabetes in general, or even if there's any specific ones for eye and.
So I think she's frozen again, but I'll just start answering the question. I think with what's common to Black populations, so that's the African and the Caribbean populations, is we tend to eat quite a high carbohydrate diet. And my recommendation would be to try and limit the amount of carbohydrate you eat. So carbohydrate is an essential building block of your food, of your nutrition. However, you do need to reduce the amount of carbohydrate, especially if you're eating this in excessive amounts. I'll just wait for Dr. Diane to return. I think she's frozen again.
Sorry, can I just say something, Dr. Tolle?
Yes, yeah, go
He
on.
also asked about preventative for the eyes.
Yeah.
Yeah, I'm the lady with ocular hypertension in my eyes. What can I do to stop it getting worse?
So you should be, so if you have ocular hypertension, you should be under an ophthalmologist. As I mentioned before, if you have diabetes, you have twice the risk of glaucoma or other complications. So you should be under an ophthalmologist. You should be on something called a beta blocker eye drop. But like I said, you really need to be under an ophthalmologist who would decide. So if you have diabetes, that in itself puts you at twice as risk of having other complications with your eyes. In terms of preventing things in general, then it's just better management of the diabetes. But once you've got established ocular hypertension, then you should be given certain medication by the ophthalmologist to try and reduce the pressure in the eyes. Does that answer the question?
It does, but what if, because my pressure fluctuates, I do have the yearly test at the hospital, but my pressure fluctuates.
Mm-hmm.
And the last time it was in a normal range.
Okay.
The last time. So what can I do to have it remain in a normal range?
So I would say better management of your diabetes, also sometimes weight as well. So I don't know if they mentioned that there's pressure in the back of the eye on the nerve, the optic nerve. I don't know if you're ophthalmologist, because I'm not an ophthalmologist, but they might have mentioned, they might be looking at the nerve, the optic nerve. I don't know if you get headaches as well. But if you are under an ophthalmologist, they should, so, you should have medication for this, but also trying to keep your weight stable sometimes helps with ocular hypertension.
Thank you.
Are you on any medication for it?
No.
Okay.
And they don't tend to give me advice. I asked them about doing eye exercises, and they were like, good God, no. And I said, well, what else should I do? And they don't really offer a lot of advice. And that's why I find it so frustrating. But you did about the weight issue. I didn't really,
And you don't, just make sure you don't have thyroid disease as well, because sometimes thyroid affects the eyes. So just make sure that you have had your thyroid checked as well.
Thank you. I didn't realize that.
Yeah, so just make sure that you have your thyroid checked with your GP. And these are other causes of ocular hypertension.
Thank you.
You're welcome.
Dr. Shani, I'm really sorry. I am really having
fine.
a lot of difficulty here. So I'm having to log on using my phone this time. And I'm trying to access the chat box. I think you've probably saved me and probably gone through some of the stuff in the chat box.
So I think someone was, there was someone who just asked me about ocular hypertension. I'll just have a look through the chat and see if there's any other questions.
Please, while I try and get myself sorted on this end. I can't see it properly on the phone, so I'm trying to go back on the computer.
So someone's asked about blood glucose monitors, how useful. So if you have diabetes and you're on insulin or medication that can drop your glucose dramatically, you need to be on a glucose monitor. And then someone else has asked a question about, for those who neither have diabetes nor foot disease, would you recommend everyone should have an annual foot check So I'm guessing if you don't have diabetes, but you're at risk of having diabetes, then I think the general advice I'd give would be to just make sure, reduce your risk, exercise, and stay healthy. But then the same principles of making sure you wear appropriate footwear, that still applies to everyone, regardless of whether you have diabetes or not. And then I think Margaret has asked, we've seen several Black people who've had amputations but do not have prosthetics. Are many not offered this? So Margaret, that question, I think that depends on the patient's choice. So sometimes when people have had amputation, depending on how high the amputation is, if you think about it, your center of gravity changes. So some people would like prosthesis, which is like an artificial limb. Some people are able to cope with that, but then that takes a lot of relearning, because essentially you're training your body to walk with something that you've never used before. So some people, so it's patient choice. Some people, if you ask for it, you should be given it. For some people, they prefer a wheelchair, because a wheelchair takes the pressure off and they're able to just move, move around with a wheelchair. So if you've had an amputation and you feel that you can cope with a prosthetic limb, then you should ask for one and you should be given one. But normally you would get assessed by a physiotherapist first to make sure that you're stable and you're safe, because we don't want people to start using prostheses and then they're falling over because the center of gravity changes. So I hope that's answered Margaret's question. Diane, are you still on the call?
I am on the call, but guess what? I think because I've had to restart everything, I've lost the pre-existing questions. So
right.
You probably have better access to it at this point.
Okay.
I will probably pick up the rest that are being posted now, but if you're happy to carry on, I will just stay in the background for a few minutes while you carry on. I'm really grateful. Thank you.
So I think we've answered, so from what I can see, I think we've answered most of the questions actually. So I think we've answered Fitzroy Beckford's answer about preventative podiatry. We've answered, I think Koja asked about whether the talk is going to be online, and I think someone's responded there's going to be on YouTube. Let's just make sure we've answered everything. Someone's asking about nighttime and cramps. I think nighttime cramps. I think we might have touched that. We've answered Margaret's questions. We've answered Monica's question. I think that's everything. I think, Diane. I think we've covered everything.
Okay, so I've got a few that have come through to me. Thank you so much. You've been great, guest and host. Super.
You learn every day.
You do, don't you? Yes, you get thrown into the deep end and you've got to swim out of it. Right.
Yeah.
Thanks for sticking with us, viewers, and thanks for putting up with all these technological hitches. Right, so we'll carry on. So another question is, I seem to get some dry dead nail. And sorry, Tolly, please, if you have said this already or answered it, please just move on, because obviously I missed some bits and I might just be repeating things that have already been discussed. So someone says that I've got some dry dead nail. I've tried a few different creams. It gets rid of it, but then it comes back again. And I've been trying for the last 5 years, even after trimming it. So this sounds like a recurrent nail problem, which the person has sort of treated over years. Any advice, please?
So it sounds very much like a fungal nail infection to me, especially because fungal infections tend to be quite chronic. They last a long time and they're very difficult to treat. So my recommendation is to see your GP or a podiatrist, and they will offer you treatment. So sometimes shaving off the dry nail, and there are sort of topical, and there are things which you can apply to it. Sometimes you might need systemic treatment, so tablets, but usually I think that, they would, depending on how bad it is, they would decide on which way you should go. So I would go to the GP or a podiatrist to have a look at it, but it sounds like a fungal nail infection.
Absolutely, I agree on that, yes. So please see your GP and we will sort that out for you. So this is picking your other hat, the endocrine side of things. If your thyroid has been removed due to cancer, what HRT can help them live a normal life? So that's an interesting one. Mm-hmm.
If your thyroid's been removed due to cancer, the most important hormone you need to be on is thyroxine. So that's the most important one. Usually, if you've had thyroid cancer, we would give you levothyroxine, and we'd give you, depending on your risk. So after you've had thyroid cancer, they classify you into different risks as to what your risk of recurrence of the thyroid recurrence of the thyroid cancer is, and then they'll prescribe you levothyroxine. So sometimes we give you a higher dose of levothyroxine than usual, and sometimes we give you a moderate dose. But the most important hormone is levothyroxine. HRT, I don't think has any relevance to the thyroid cancer, in all honesty. Your HRT would the choice of HRT would depend very much on your blood pressure risk of blood clots, risk of cancers and breast cancers, risk of womb cancers as well. So that would be, that would be your choice of, and that's something which you discuss with your GP.
Thank you. Thank you very much for that. Just a reminder, lovely viewers, that the feedback forms have been posted. Please do fill them in. We do value your feedback. It's important to know whether what we're doing is useful. And also do feel free to let us know the topics that you'd like us to discuss in further sessions, in subsequent sessions. We want to make this as relevant as possible. We want to bring you the stuff which is beneficial to you and which you find relevant. So please, we do really appreciate your feedback. So I've got Dr. Ambrose on the call. He's had his hand up for a while. So Dr. Ambrose, if you're able to unmute yourself and briefly ask your question, the floor is yours. Are you still there, Dr. Ambrose?
Sorry, I think it was a legacy hand. I didn't mean to raise. Sorry.
Right. Okay, so you don't have a question then?
No, I don't.
Okay, fine. That's okay. The joys of technology, isn't it? It puts your hand up even when you don't intend to. Right. So apart from reducing carbs, Dr. Tolu, any natural plant-based products? I think you've touched on that already. Did you want to add anything special to that, please?
No, I think it's a balanced diet. So it's reducing, limiting. So you, like I said, carbohydrate is a building block of nutrition. So you can't completely eliminate it, but it's trying to make sure that you have a balanced diet. So there's carbohydrate, there's some protein, there's, there's low fat. So you're going for low fat meals. And just making sure that you're eating plenty of fruit and vegetable. So this is just to make sure that you have a balanced diet, but a nutritious meal. So that's, I think those are the general principles.
Thank you. And I know that we've talked a lot about things that we probably assume are more in older people, because obviously as the diabetes progresses or is less well controlled, we get these complications. Is there any chance that children can have some of these complications? So is it possible for children or teenagers to have foot complications, to have eye complications, for instance, if they're type 1 diabetics or, that sort of thing?
Absolutely. So quite commonly, because people who have type 1 diabetes have been diagnosed at an early age, so they tend to have complications, start developing complications 2 decades before, the age-related counterparts. So we have quite commonly, we've seen a 20-year-old have a stroke with type 1 diabetes. We've seen a 30-year-old have bilateral knee amputation. We also have had, they've completely lost their sight. So what typically happens when patients with type 1 diabetes are diagnosed, sometimes, not all of them, but sometimes when they go through the teenage years, sometimes they can go through a rebellious phase. And unfortunately, that's the time where all the complications really manifest. So by the time they get to their 20s, their 30s, they're developing diseases, like heart strokes. We've seen a stroke in a 22-year-old. We've seen heart disease in 30-year-old, 40-year-olds. So they start to develop complications. So the main thing is, as soon as you've been diagnosed, stay on track. Because if you stay on track and keep things in control, then you reduce your risks of having these complications. So yes, definitely, absolutely. We see complications in young patients a lot of the time.
So that's really important, isn't it? So it's not just for the older folks or older patients. Younger patients can have these complications as well. And I really sort of see that point of when you say they disengage sometimes in the teenagers. I see that a lot in clinic, where it's more difficult for teenagers to be compliant with their medication or their insulin or their diet or whatever they need to be doing. And sometimes we have difficulty keeping them on track or getting them to see the point for a number of reasons. And we know it's quite challenging, but it's really important that if we don't keep on track, then we could end up getting complications a little bit later in life, which may be 30s or 40s for you. And someone has put their hand up and said, yeah, I'm guilty of that. So we do have real life experiences on there. Thanks for really hammering that point for us, Dr. Shani Barry. Doc, why can't a person with high uncontrolled sugar level not be given insulin until it's settled down and then provide them with tablets afterwards as a maintenance dose? So if someone has high uncontrolled sugar levels, why are they not given insulin? Oh, okay. So it's the other way around, isn't it?
Yeah.
So I guess someone probably has the impression that if you have an uncontrolled glucose level, you cannot have insulin until it's settled down. Can you kindly clear that for us and clarify that misinterpretation or misunderstanding, so we leave here absolutely clear in our heads when can we go on insulin and who cannot go on insulin and all of that? Thank
so
you.
if you first present with a very high glucose, so it's uncontrollable, actually the first choice of drug we would use is insulin. Especially if you're a new presenter with diabetes, any form of diabetes, we would use insulin first. If we're able to get things under control, then we reassess to see whether tablets enough would be suitable. But actually, if you have a very high sugar, the first thing we would go for is actually insulin. Sometimes it could be that, you've presented for the very first time, you just needed to get things under control. And if you're able to make the changes, lifestyle changes, then you can go on tablets or sometimes diet alone. But if you first present with a high sugar, then most clinicians would be using insulin straight away. So.
Thanks for clarifying that. Another lady's comment: I am a pre-diabetic on the NHS program. My GP will only do an annual check. I want a full check at 6 months to see my progress, where I am now, because I'm exercising 3 times a week and I've reduced my carbohydrates by 50%. What can I do?
So I think now they've extended the annual checks to people who have pre-diabetes, because they've realized that sometimes people who have pre-diabetes sometimes start to show problems with the eyes, at the back of the eyes. So it's still, because of the way medical services are commissioned, it's still annually. If you felt that you wanted to have another test, then you can arrange this privately. But at the moment, it's only commissioned for an annual test, unfortunately. But it sounds like you're doing the right things. You're exercising 3 times a week. And so I'm sure that by the time a year lapses, you would find that you're actually on track. So I wouldn't get discouraged by not having a 6-monthly check, but it sounds like you're doing the right things. And I'd encourage you to continue.
Thank you. So well done to that person. Keep doing the right things that you're doing. Last week, Dr. Tolley, you spoke about diabetes or in pregnancy, and how likely is it to get foot and eye complications during pregnancy? And will the signs be the same as what you said, or are things like foot swelling in pregnancy, for instance, a possible sign of diabetic foot disease?
Yes, so in diabetes, so when women get pregnant, sometimes the complications actually get worse, because if you think about it, the body's suddenly put under pressure to supply blood supply and nutrients to a fetus. So sometimes women with eye disease, their eye disease gets worse in pregnancy. So that's why we always suggest that as soon as you get pregnant, you should, if you've not had an eye test within 3 months of getting pregnant, you would have an eye test done. And then you would have an eye test done initially. And then if there's any signs that there's a problem, then you have further eye tests, for instance, in each trimester. Sometimes you just have the eye test done twice, on the 1st and the 3rd trimester. But, if you've not had an eye test before pregnancy, then you would have one done straight away. And then the ophthalmologist will decide how quickly they want it to be, how quickly they want to bring you back. Sometimes women do need treatment, so sometimes women do need laser treatment, but a lot of the time they would just monitor it just to see, and a lot of the time the way to manage it would be controlling the blood glucose and the blood pressure, and that's enough to keep the eye disease from getting worse.
Thank you.
What was the second question? There was a second part to the question. What was the second part?
No, so she was asking whether the symptoms that present, for instance, foot swelling, could be a sign of diabetic foot disease, or whether there are different presentations that you would get in pregnancy.
So if you're pregnant and you have foot swelling, that could be, if it's just, that could just be that you're carrying carrying a baby that's pressing on your blood vessels, the feet or the legs. So sometimes people have what we call edema, which is foot swelling. So there's blood pooling at the leg, there's blood or water pooling at the legs because of the pressure of the baby just pressing on the blood supply. So that's a common reason for why women and pregnant women have swollen feet. If you're noticing ulcers or change in sensation, then yes, you would need to have that checked. Typically in our joint antenatal clinics, we always check everyone's feet. So if you book into our clinic, we'll check your feet to make sure everything's okay. But if there's a problem in between, let someone know.
Okay. And I must say the comments that are coming are really powerful for you. Well done. This has been so useful, so educative. Someone has even commented about your respectful manner, the fact that the NHS learn a lot from you, and lots of us have learned a lot from you over these few sessions. So we are really grateful for your time. Plus, you've done a bit of the hosting for me as well. How wonderful is that? Right. One last question, and then hopefully we'll let you go. I know you've probably talked about it, but the fact that someone has asked again probably means a little bit of clarity for that particular person or for anyone else. What can I do when I'm having pins and needles? So they haven't specified whether it's in the feet, but just briefly, what can somebody do if they're experiencing pins and needles?
So if you are experiencing pins and needles, I'd encourage you to check your feet to make sure there's no ulcers or any wounds on your feet, and then go to your GP. So if the pins and needles are particularly problematic, the first thing you need to review is if you have diabetes, then you need to make sure that your diabetes is well controlled. Sometimes there is therapy for the pins and needles. The duloxetine is what we use as a first-line therapy. There's other drugs which we can use to try and alleviate the pins and needles. But so that's the first thing. So good diabetes control, good blood pressure control. There's also medication for the pins and needles, and also keeping healthy and active as well. So if you stay active, that improves the blood supply to the leg, and sometimes that could help with the pins and needles. So yeah. And
are the dental checks free? Are there free dental checks for diabetic patients at all?
I'm not too sure about the dent, because I know the dentists work slightly differently. They tend to do mainly private work, but I'm not sure. But if I would go and find out that information, but I'm not too sure if people with diabetes have free dental checks, but I would check to see what's available in your area. Yeah, I'm not aware of that either, but certainly check what's available in your area. Yes, okay. So Dr. Tolu, it's been an absolute pleasure having you on again today, and thanks for the wealth of knowledge that you've imparted to us, for the insight. And well, someone has said, no, we don't. So I guess that person is probably a dentist or a dental fraternity person. So but back to what we were saying. Thank you so much for everything that you've taught us, shown us, explained carefully to us, so that everyone leaving here hopefully is equipped to manage their diabetes better, or to know what to look out for, or to prevent themselves becoming diabetic in the first place. I think you've emphasized the point over and over again that having a good diabetic control is the key to preventing most or all of these complications. So the take-home message, if you take nothing at all, is make sure that hopefully, if it's within your power, you don't get diabetes in the first place. But if you do, make sure that you're managing your diabetes really well. You're following the advice that you've been given. You're engaging with the process, with your screening, with your treatment, with your management. And if you've got any concerns that you're unsure of, speak to your clinician or speak to your GP. Thank you so much. Any last words? So I think the three things, like this, my take-home message would be, number one, if you don't have diabetes, know your risk. Number two is, if you have diabetes, know your numbers. And the third thing would be to stay on track. And the fourth thing is always seek help early. So those are my parting words. Thank you. Excellent parting words. Thank you so much, Dr. Tolulope Shonibare, our consultant, diabetologist and endocrinologist, who's taking us through the session. Thank you so much to the team. And I will hand over to the team to carry on now with the rest of the announcements. It's been my pleasure hosting you as well. And thanks for putting up with all my technical hitches. Thank you. Thank you.
Oh, thank you, Dr. Tolu Shonibare. That's fantastic. Thanks for your informative session. A topic not to be taken lightly. Also, thank you to our host, Dr. Diana Asante. And thank you to all our attendees on Zoom, Facebook and YouTube. If you would like to access today's Health Hour session, it will be available on YouTube. Sorry, I've just lost my Yeah, so if you would like to access today's Health Hour session, you'll be able to find it on our Facebook page, also our YouTube channel, along with previous sessions. And to receive a copy of the presentation slides for this session, please email your request to health@cahn.org.uk. Also, please do complete the evaluation link, which was put in the chat, as we would love to receive your feedback and ideas, as Diana stated also. Again, if Nicole can put the link in the chat for those who haven't completed it. And we'd also like to, I'd also like to share some upcoming events with you and opportunities that you can attend, and do share them with families and friends, and do put them in your diary, because everyone is welcome to attend. And Nicole can put the flyers in the chat, please, so I go through the information. So our next Healthy Heart session is going to be on dietary management of diabetes in children, and that will be by Dr. Alistair Kimmy, who will guide us on this topic, and our physical instructor is Orlando Grant, who will facilitate the box exercise session. And this session will be on Tuesday, the 31st of May, at 6 till 7:30 p.m. And for any queries or further information, please email events@cahn.org.uk. Next slide. And please do join us next week for our next Health Hour session, which will be a session on monkeypox by Dr. Vanessa Appiah, who will be our guest speaker. And if you want to register for the event, please go on, email events@cahn.org.uk. And for further information, you can send an email to health@cahn.org.uk. Also, we do have Enfield Black Community Health Forum. They're launching an event, and this event is to celebrate and acknowledge the rich diversity, culture and heritage of our community, and that's in Borough of Enfield. And that will be on Saturday, the 28th of May, 1 till 5 p.m. at 47 London Road in Enfield, EN2 6DS. And for further information, please email communityengagements@cahn.org.uk or call 077 100 22382. We also have gambling awareness workshop, which you can attend, and that will be on Monday, the 6th of June, and the time will be 6 till 7:30 p.m. And to register your interest, you can go to this link, which is portal.cahn.org.uk /gambling awareness workshop. Or for further information, please contact us via email at communityengagements@cahn.org.uk. We also have our Windrush event, which is coming up soon, and so do join us on the 25th of June at Alexandra Park, and it will be at 12 till 6 p.m. To celebrate this fantastic event. And you can also again register your interest at portal.cahn.org.uk /Windrush Day 2022 to attend. And if you want to register for a stall at this Windrush event, please do call 07312 082832 and or email windrush@cahn.org.uk. And if you need any support at all regarding domestic and or sexual violence, we do have a helpline that you can contact for counselling or practical support, and the number is 077 100 228 We also have family and advocates support services, monthly sessions that you can attend, and that's 6 till 7 p.m. And also, if you want to email us, you can email us at help@cahn.org.uk, or you can call or text 077 100 22382. And that's our event. So again, thank you very much for attending our session today. It's great to have you all on board and to see you today. And don't forget to attend next week for our session on monkeypox by Dr. Vanessa Appiah. So do take care, do contact us if you've got any queries at all, or if there's anything that we can help you with. Enjoy the rest of your day, and see you again soon. Thank you. Bye, everybody.